Everyone pretty much has a family history of cancer, and in the vast majority of cases, breast cancers in a family are not due to any underlying gene problem. But there are some key indicators we would want you to be aware of. A patient's risk can be increased because of family history on either side of their family, so maternal or paternal. And the types of things that in genetics would make us a bit more suspicious of a possible underlying inherited cause are breast cancer diagnosed at an unusually young age, multiple primary breast cancers in an individual, breast cancer affecting several closely related members of a family, or breast cancer that we see alongside other types of cancer that we know can be linked to breast cancer through gene problems. So that would include ovarian cancer, male breast cancer, and prostate cancer. It's also true to say that there are some specific features of a breast cancer that can make us a bit more suspicious of an inherited link. So triple negative breast cancers, for example, are a lot more likely to be due to an underlying gene problem. All regional genetic services have referral criteria. The criteria for familial breast cancer will in the main be based on some nice guidance criteria for referral to secondary care for familial breast cancer. So if you really can't locate your local services referral criteria, the nice criteria will be very similar, if not identical. So we would hope that you would use those criteria. Though it is worth mentioning they do need to be applied with common sense, and bearing in mind that patients and their families quite often defy categorization because information about relatives can be unclear for a multitude of reasons, things like poor communication from families, estrangement, adoption. So if their circumstances muddy the waters somewhat, I would say do refer them in with as much information as you can, but do note if there's some uncertainty about some of the information with the referral. So most genetic services will ask for a family history form to be completed, which is quite a hefty document asking for details about relatives and cancers diagnosed in the family. But we use this to verify the cancers and then assess them in the context of the family tree. In the West Midlands, we have an online version of the family history form that can be downloaded and a facility to complete the document online. GPs are also very welcome to include a cover letter with this document if there's further information that they wish to supply. If a patient is referred without a family history form, we'll very often reject the referral and ask them to complete one, and then really the processing of referral begins when we receive that family history form. Practice in other regional centres may vary. It's also worth mentioning that if you have a family where there is a known gene problem, where there's an identified gene problem, please provide as much information about that as possible. So who the relative is that's been tested. If you can get a copy of the reports to include in the referral, that's really useful, or a reference number, or just an indication of who that relative is and where they've had their testing. Titles of the increased risk groups can be a little bit confusing because for those patients who are at an increased risk, we sort of have three groups. There's the moderate risk group, the high risk group, and then separately the very high risk group. The moderate and high risk groups are stratified based on estimated risks of developing breast cancer. And we usually lead to recommendations for annual mammography from age 40. And that would be until age 49 for moderate risk patients, or until age 59 for high risk patients. And after that increased screening ends, they would typically then join the national breast screening program for 3-yearly screening. So that recommendation is usually sent in a letter from genetics. If a young woman is recommended to have breast screening, which is then starting at a later stage, we tend to send this recommendation to the GP and ask the patient to get back in contact to chase that up with the GP when they reach age 40. But separately, we have the very high risk patients, and these are the ones who typically have an identified gene problem, so a problem with something like BRCA1 or BRCA2. And for these women, as I mentioned, their screening can start as early as age 25, starting with breast MRIs, and then we bring mammograms in additionally from age 40. This screening is organised through a separate screening pathway, which is called a very high risk screening pathway. And this is all organised through genetics, coordinating with those specialist teams. Patients in that risk group may also choose to think about things like risk reducing surgery and use of the hormone blocking drugs. Somatic genetic testing is testing of tumour tissue. So it's testing specifically of the cancer rather than the genetic material with which a patient was born, which would be taken from something like a blood sample. So a key characteristic of cancers is that their genes change and develop as the cancer progresses. And there are some specific changes which, if they're present and if they're identified, they can direct oncologists to help their own therapeutic account, to direct their therapeutic approach. But just because a gene change is identified in a tumor, it does not necessarily mean that it will be present in the DNA that individual was born with. In fact, in most cases, it isn't. So this testing, the somatic testing, is generally organized by oncologists and not through genetics. And if somatic testing results do suggest a possible inherited link, which does happen, this would be clearly highlighted in the lab reports, and the recommendation would generally be for the oncologist to then refer that patient to clinical genetics. If patients are eligible, please do give them a copy of the family history form to complete. If there's anything extra that isn't covered by the family history form, please do send a cover letter with the family history form. If there is a known gene problem in a family, please include as much information about that as you can. And if patients are referred to genetics, the genetics team would then issue advice for any risk management, any further steps that we think need to be taken.